I'm Afua Hirsch, and this is the second episode of the COVID report. We keep being told that the government is following the science. What does that even mean? In this half-hour show, we're not going to follow the science in the way the government says it is. We're going to question the scientists. We've brought together 4 leading experts in different aspects of COVID-19 because we want to find out what it is we do know and what it is we don't. What is it that we're not being told? This week, we've seen record numbers of people dying. An expert saying that we in the UK could see the worst death rates in Europe. The experts joining me tonight are Anthony Costello. Anthony, please introduce yourself.
I'm Anthony Costello. I'm Professor of Global Health at University College London, and for 3 years I was a Director of Maternal and Child Health at the World Health Organization.
And Allysson Pollock.
I'm Professor of Public Health at Newcastle University and also a consultant in public health medicine.
And Dr. Bharat Pankhania.
I'm Dr. Bharat Pankhania. I am a Senior Clinical Lecturer at University of Exeter Medical School. I did communicable disease control for 20 years and my last job was at Public Health England.
And joining us for the first time this week, we have Dr. Rosalyn Moran.
Hi, I'm a reader in theoretical neurobiology at King's College London and a modeler.
Thank you so much all for joining us. I'm really looking forward to getting into the facts with you all. I want to open this up with a really big question. The head of the Wellcome Foundation has said Britain could have the worst death rates in Europe. Does this shock you, Anthony, or is this in line with what you have expected from the disease and the way it's affecting us here?
Well, it is. It's absolutely shocking. It's a public health catastrophe. And if you think that, the US, South Korea and England and Wales, UK, had their first cases in end of January, their first deaths at the end of February, early March for the UK. And now Korea has had about 240 deaths. I think their rate is 4 per million. We're up at 170 per million. And we'll come on to Rosalyn's model later about projections of deaths. But if we've got 12,000 now and you have to add on at least half again for the community component, that's 18,000. If we're going to have the same deaths on the way down as the way up, that takes us up to 36,000. And we haven't included care home deaths yet. So we're heading up towards over 40,000 deaths. That will make us 200 times higher than Korea. And it could easily put us in first place for the world, although I think the US may rival us for that rate. So this is the worst public health catastrophe of the last century. We have to ask questions about why it's happened.
That really does put these figures into context, Anthony. Thank you. And you mentioned deaths in care homes. Allyson, you spoke so passionately about this last week. The ONS statistics give us some picture of the gap between the number of hospital-registered COVID-19 deaths and the extra deaths recorded outside of hospital, although we don't know exactly how many of that 6,000 extra deaths than we would expect from this time of year are actually taking place inside care homes. What do we know about what's happening in care homes? And do you feel like we're finally beginning to get the level of interest that this crisis warrants for people in that position?
Well, it's the final irony that the government said it was intending to shield older and vulnerable people. And it's the one group that we know has absolutely not been shielded or protected. We know from the rest of Europe that about half of all the deaths have occurred in care homes. And it's very likely that we might see a very similar picture here, with Scotland and the UK reporting increasing numbers of deaths across all the care homes. And that's very worrying because, of course, what we don't know is some of these deaths maybe should have been hospitalised and may have been preventable deaths. And some of these deaths may, of course, be the tragedy of COVID and just not managing to survive it. But what we do know is that at the same time, there are about 500,000 people in care homes. But the problem for the government has not been able to get a handle on the care home sector. And that's because there are over 11,000 homes and over 5,000 different providers. And there is no systematic, comprehensive data collection, either on the residents themselves, or indeed in terms of detail about the staff, the staffing levels and the staffing numbers. And there are about 1.5 million care workers in both the nursing home care sector and the social care sector, most of whom are low paid, but we really are not documenting what is happening to the staff, especially whether they're working because when they're sick because they're on 0-hour contracts and they feel they have to work, whether they're agency staff that's moving from one care home to another, and that's the way in which the disease is moving around. So the government it's a disgrace and it's a national shame that the very group that we were supposed to be protecting is currently the most exposed in this country. And so little has been done. And only now that the deaths are piling up and piling up is attention actually being paid to this sector. But it's far too little and far too late. And it's an absolute shame for the country.
Baroness Altman described elderly people in care homes, and of course it's not only the elderly in care homes, but many of them are particularly vulnerable, as being like lambs to the slaughter. Bharat, does that strike true with you in your analysis of what's happening outside the hospital setting right now?
Yes, thank you. And my colleagues, both Anthony and Allyson, have clearly articulated the same concerns that I have. Furthermore, if I can add, we've just gone into a lockdown without any idea about what it means. All they have said is we are shielding the vulnerable and the elderly and the at-risk. What does shielding mean? Has anybody said, and shielding will look like this? In other words, I'm very concerned about elderly people in care homes, nursed and looked after by healthcare workers, but those healthcare workers are going from home to home to home in many instances, and there is no quality control over what personal protective equipment that they wear, and when they see the residents, who they are seeing, and if they are ill. And as Professor Allysson Pollock has clearly said, many of them are on 0-hour contracts, and as a result, they have a compulsion to come to work even though they might not be feeling right. And therefore, there is an inevitability that infection will be brought into these homes. And one more thing that is striking me is the care homes, the nursing homes almost seem to accept fait accompli, meaning, what can you do? We've got these people here, we'll just keep them and then they will die. And I think that is unacceptable. It is unacceptable that people have just almost withdrawn healthcare services from these elderly people in their care homes. We haven't got a bombing raid going on or anything like that, whereby a suitably attired general practitioner cannot turn up and check on this patient to see, do they really have coronavirus infection? Do they have something else? Are they amenable to intervention? Could we save their lives? All lives are worth saving, and we shouldn't just say, it's care home, it's the elderly, what do you expect? No, people die naturally, and we have to keep them alive. And that's what we do. We should.
And I agree, Bharat, because it's a really terrifying time for relatives, for carers, and for the people in homes. And some of the people I've spoken to in homes have now been trapped in their rooms for over 3 weeks, only getting meals.
Yes.
Nothing else, and some room cleaning.
Yes.
And they've been trapped there without any relatives, with depression, with dementia, deep distress. And the other thing is the relatives are not getting a proper handle on what's going on.
I just wanted to add, if I may, from what Allyson was saying, which is, this is sleepwalking. How is it possible for the nursing and the care homes who have developed their own modus operandi and then carry it out without challenge? So The elderly are kept in their rooms, as Allyson has said. They're brought food to their room, and then that's it. You stay locked up in your room. You're elderly, your mind may be wandering, you may be frightened, you may be scared, no visitors, no doctors coming in, and you stay in your room. How and who is making these rules, and we're accepting them? Why isn't there an outrage that surely you can't be just making these things up as you go along? And as again Allyson has said, if there is a desire to do it centrally, manage it, control it from the headquarters upwards, then you will actually have a consistent pattern of minimum standards. Thank you.
Thank you very much. I just want to, we're obviously concerned about what's happening now, rightly so, and some very big structural issues facing the care sector, but also some immediate tangible things that could be done immediately to start alleviating the situation we're seeing there. But I want to come to you, Rosalyn, because you've been looking at a very difficult and complicated mathematical model of what could happen in the future. And this is the other issue, of course, that we're all facing. We're all asking, how long will this go on and how will we come out of it? Could you outline your work for us?
Yeah, sure. So just to say, obviously, the numbers and the situations are very sad. And when we're talking about projections, both from the Director of Wellcome Trust or my model or other studies that we've seen, they are just projections based on what's in the rear view mirror. So they're not inevitabilities or foregone conclusions. But what my team and I have done is looked at two models. So we repurposed brain imaging technology to take a look at two models that can try and use the best parameters or understanding of the disease transmission properties that we have today, which is still unfolding, and predict basically the size of the whole population that are involved in the outbreaks at the moment, and to look at the projected case numbers as well as deaths. And so effectively what we're asking is how many people have gone through the cycle of potentially being susceptible to this disease, being infected, and then either recovering or unfortunately dying from COVID-19. And so what we used was a traditional SCIR model, so one of these models that you've heard of, susceptible, exposed, infected, recovered. And we compared it to something called a dynamic causal model developed by Carl Friston at University College London. And unfortunately, both of them predict the same sort of rates of death potentially in the UK, bearing in mind, again, that we're basing it on data that we have in the past and the data that's available to us. So they were taken from Johns Hopkins University, CCS statistics. And the numbers that we came up with were bubbling around above 40,000, so around 49,000. But the bigger question of the study was whether this was the end of the pandemic and how far we are down the road. And for that, what we found was that potentially the total size of the UK population that may be involved in the number of outbreaks that we're seeing now is still quite small. So it may be as low as 20% or lower. And so what that means is that there may be future cycles of cases and of deaths. And so what we may need to consider is strategies that would try and prevent these second waves, since we're seeing this sort of peak of cases and a delay in the deaths, but they're hopefully dropping in the next week or so. And so basically what we're projecting overall in our model is the sort of number that you would get from testing, doing a serology test or looking at the antibodies, and then hoping that people, once they've been infected, are immune for at least some time. And so, yeah, that's where we are. So some sad numbers, but as I said, not set in stone and all open to interventions of the kind that Bharat and Allyson have been mentioning on this program before.
So what, and sorry to reduce something so nuanced to headline figures, but what are the headline numbers that you found through your modelling?
In these two particular models, we saw in this wave that the death numbers may be around 49,000.
And Anthony, I want to come to you because I know that you have also found Rosalyn's work incredibly useful. Could you give us your perspective as to how these kind of numbers and this kind of modelling can help us in working out the correct approach to the crisis that's clearly still unfolding?
Look, I'm not a mathematician, but they laid out very clearly in the papers and in the video that Carl Friston ran, the logic behind it and the sophistication of this model. And the most important thing, I think, was that they said, as Allyson has been saying before, and we've all been saying, this is not one epidemic. This is a cycle of epidemics that are going to hit us, which start in particular areas, particularly cities. And they came up with what they call the effective susceptible population. By that, and Rosalyn will correct me, I think they mean the people that actually are being hit by the epidemic within the country in this cycle. And the staggering figure they come up with is that at the end of this cycle, whatever the mortality rate is, only 6.4% of the population will have actually been covered by the infection. So if you go back to what Sir Patrick Vallance said, which was you need to get 60% of the population to have the infection in order to have herd immunity, it implies that you would have to go through another 8 to 10 cycles of this kind of infection. And given that this cycle may well end up with their figure, I thought at first it seemed very high, but the more you look at the figures and the community and the care homes and the fact we're not even at the peak yet, 49,000 deaths is sadly a possibility. So you multiply that by 10 and you know what you get. So I think this was incredibly interesting and tragic. And we have to think, because everyone is saying, you know, the financial markets at the moment are going crazy saying, oh, well, we're nearly over this pandemic now. And yet we're over like the first 6% of the population to get infected. And all the Asian states that have suppressed it, like Korea, like Japan, like Taiwan, China, and the rest, are already seeing new outbreaks. But they've got in place this kind of community protective shield that is trying to spot the outbreaks when they occur and damp them down. And what worries me, and Allyson might have something to say about this, on March the 12th, when we put out this kind of herd immunity policy, we then said, well, you know, it's going to take a while to damp down and we're going to stop all contact tracing in the community. That was when 97% of our population didn't have any infection and many people lived in areas where it wasn't really a big problem. And yet we removed that protective shield then and we haven't reinstated it. So we've got probably another 4 to 6 weeks of this lockdown. We should be working night and day now to restore that community protection so that when the next cycle, which will affect another 7 or 8% of the population, if Rosalyn's model is right, how are we going to protect and damp it down in the way that Korea did and we failed to do because we acted far too late?
Listening to this, I'm struggling to understand the decision to advocate herd immunity, followed by the decision not to increase testing to a level that would make sense given the numbers that Rosalyn is projecting. Bharat, it feels as if the government has been on the back foot at every stage of this, and now that we're seeing these projections, remains on the back foot. What do you make listening to Rosalyn's research?
Can I say that as a former consultant in communicable disease control, managing outbreaks all the time, we feel that the voice of the consultants in communicable disease control types has not been heard at the top table. So whilst the modelers have been heard loud and clear, people like myself were already talking about control measures, projections, exponential rise in number of cases, all those fundamentals we were saying. And then let me go back to South Korea, as we have been mentioning it. South Korea, etc., were not driven by the modeling information. They were driven by basic science of communicable disease control, outbreak management. And that is what they did. Identify, contact trace, isolate, test, all those things that we have been advocating. Now that we have a shutdown, it is a second chance that we have got to replenish and build up our stocks of personal protective equipment, respirators, and all the other accoutrements that you need to handle the rise in the number of cases that will inevitably occur when you are going to lift your shutdown.
Yeah, and Bharat's absolutely correct. And the key, as Anthony says, is to remember this is not one big national epidemic. It's lots and lots of outbreaks occurring at different phases, and they're all at different stages. And every single one has to be managed and controlled, whether it's in a nursing home, or whether it's in Rutland, or the Isle of Wight, or Blackpool. And what you now need is the government to build up the community side. It's put in hundreds of millions of pounds into building these Nightingale hospitals and getting them off the ground. It has not invested anything into the field epidemiologists and Public Health England into getting, with local authorities, getting the information at local level and doing the track and trace. This is the mantra, you know, we need to do contact, we need to track the cases and the contacts, isolate and quarantine. And even if we don't have enough tests, that doesn't matter, because clinical observation is actually better than testing. Many of the tests give the tests are 50% false negatives, so you have to redo the tests, but clinical observation is key. And I know I said this, I'm at risk of repeating myself, but the government is still not listening, and it still doesn't have these local action plans. And if it had had these plans, there are many populations that would have been protected from the worst of this epidemic, because the government would have then acted faster. It would have put in cordon sanitaire, for example, around Orkney and the Western Isles. It would have done something about Rutland, the Isle of Wight. The areas where really there weren't very many cases, it could have been taking a lot more local action. And it has refused to build the capacity that it decimated over the last 20 or 30 years.
Yeah.
Bharat, sorry.
Yeah. So when the government, Bharat, and I want to put this to you, when the government says it's following the science, what exactly, from your perspective, does that mean? Because it certainly seems as if authoritative scientific opinion from people who've spent their careers working in this field haven't necessarily been listened to.
But when you say you're following the science, it is clear you're following the science of the group that is giving you the advice. And I have said consistently, that group needs to have other advisors on it as well. You know, people who deal with outbreaks on a daily basis. Their representative voice needs also to be heard. We have very clever people advising the government, but that doesn't mean that the group has to be a finite small number advising the government. Now, to just emphasize,
fair to say they haven't even published the names of all the people on that scientific sage on the site. I mean, that's extraordinary, not to publish all the membership of the group and not to put in the minutes of every meeting. This is a really secret process, and it's unacceptable in this country.
The other thing they didn't do was they didn't analyze or model the effect of testing, because they were told we didn't have the capacity and they didn't think about it. And I've got a question actually for Rosalyn, because I think your model may be able to look at this at some stage and look at cross-country comparisons. But this afternoon, I did a little thought, so I'm not maths at all, I'm O-level, you know, but I thought about the bloke that flew in from Wuhan to Seattle, okay, in, you know, mid-January. And basically, the Americans did nothing for 2 months. So I said, if you're doubling every 5 days, and if you've got a reproductive rate of infection of 3, what would one person over 60 days end up with in terms of cases? And I just did the sums all the way up, and it comes to 510,000 cases from one person. And then I said, well, supposing your career, and at 10 days, you intervene with a testing program that drops it from 3 to 2. And just dropping it from 3 to 2, you end up not with 500,000, you end up with 9,000 cases. And if you drop it to 1.5, it goes down to 500 cases. So it kind of shows you the power. But my question is, in your model, because you have a whole number of where you are in the testing thing, do you have any data that you could plug in from Korea and compare it with us? Because when you run the slide, it looks like Korea versus the UK or US, because there's this astronomical exponential rise in cases because no action was taken.
Yes, so both models, and just to say that none of this modeling should in any way detract from the contact tracing and testing that Bharat and Allyson have spoken about. But in terms of, yes, modeling, what is the effect of removing yourself, quarantining your contacts, you can certainly estimate those, and those are the things that will bring the number down. So you can see from the model that by reducing our movement around from meeting 10 people a day to 1 person a day in your home, what effect that will have just in the way that you did. And we can fit that to data. We haven't looked at the Korean data yet. We were focused on Europe, but that's something we can study in great detail, particularly with the DCM, which factorizes lots of these different options of where people can go once they're given a test, or even if they don't have a test, but they have clinical symptoms and a suggestion that they have the disease through clinical symptoms. We can
because Korea had become almost the gold standard. And if you go back to what they did, because they had the same epidemic at the same time, they, from the middle of January, they said, we've got a test. We had a test in January the 11th or something, January the 13th. But they then spoke to their pharmaceutical companies. They spoke to everyone and said, we've got to get this really going. Whereas our scientific advisory group said, don't bother with testing, I think. I mean, I mustn't malign them, but that's what's coming out from the first meeting they had at the end of January. So I actually think we could look at just the simple impact of them testing and getting it in within 2 weeks compared to us in the United States, seeing this exponential rise, which is now leading to all these tragic deaths.
And on the question of that rise, Rosalyn, actually, just to understand that you're seeing this not as one epidemic, as you said, but there will be, according to your models, successive waves. Could you just give us a sense of the scale of these waves? If you're projecting 49,000 people dying in this current wave, what does that mean for the long-term projection of the number of people who could lose their lives?
Well, what we think is that there may be the potential, as Anthony said, from sort of 3 to up to 10 subsequent waves, and it's unlikely. The easiest way to think about it is it'll look like from January to now again 5 times, but because we might have some people who have gone through the cycle already, they may be dampened. So it's hard to know exactly what the cycles will exactly look like, but potentially there could be the same number of cases again without having this extensive contact tracing and quarantining and isolation. They could basically replicate what we've seen.
And is that also the case for other countries? We've been talking about Korea. You've looked at other European countries that seem to be coming out of it and are now easing restrictions. Are they also facing these kind of resurgent waves that will then bring them back?
Yes, potentially. So there isn't something special about the United Kingdom in this regard. It's the same sort of magnitude of people who may still have to go through these outbreaks in at least the 7 countries we studied, which United Kingdom, Ireland.
Can I just add, before we lose track, I don't want us to forget what Allyson has just said, which is we have made no effort to gather an army of people who are going to do contact tracing, right? I see no evidence for it. Either we are going to do it or we're not going to do it. At the moment, we're in a state where it looks like government doesn't want to do it. One more thing, this is really, really important. We have people at home told by 111, just see how you go with your coronavirus infection. I think it is unacceptable. We need a system of following up these people, because some of them will be presenting to hospital too late and some of them will die at home whose lives could have been saved. So really, we need a system. We need a system whereby if somebody is diagnosed with coronavirus COVID-19 at home, that somebody somehow is monitoring them via these big, large call centers that I'm advising, so that at least on a daily basis, by text, by email, by phone, by some means, their status is checked. And if they are declining, they're brought into hospital sooner rather than later. That investment needs to happen immediately.
And also the digital tracing, that could happen, where people monitor their own symptoms. But can I just raise one final thing with Rosalyn about social distancing? Because clearly, that we're a 1-club golfer at the moment. That's all that they're doing. They're saying social distance. But actually, your model showed that UK had a rather unsatisfactory system of social distancing. We were some of the worst in Europe. Why was that?
Well, I'm not sure we quantified exactly how well we were doing socially distancing, but this might be part of the reason why the numbers are high. in terms of deaths. But I think what we do definitely know from the model is that if we take away the infection now, there might still be the potential for it to reemerge later. And so by being excellent social distancers, we may still have many more outbreaks to go, which makes even more imperative the need for extensive contact tracing and testing and the community lines that we've heard of.
We have to end there. A really important reminder as to just how high the stakes are for getting this right, which is why we're doing this. We are a group of volunteers, the citizens. I'm Afua Hirsch, and this was Dr. Anthony Costello, Dr. Allysson Pollock, Dr. Bharat Pankhania, and Dr. Rosalyn Moran. Please follow us, The COVID Report, on social media and look out for new episodes coming soon. Thank you all so much for joining us, and thank you for watching.